Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Hello and welcome to TCN Talks. I'm excited about today's show. Our guest today is, I'd like to say this, the infamous Dr. Joan Teno. She's an adjunct professor of health services, policies, and practices at Brown University. And I've been looking forward to this show. Welcome, Dr. Teno.
Oh, thank you for having me today. And in advance, to anybody who's listening who hears dogs barking, I'm sorry. It's a natural side effect of being a telecommuter these days. It's really their home. It's not my home.
Well, Dr. Teno, what does our audience need to know about you?
Well, I'm a baby boomer that is in the process of retiring. After 30 years of academic life and trying to focus on improving quality of care for the seriously ill, I'm in that phase-out phase of my career. So rather than abruptly quitting, I stopped clinical practice last year. And I'm now working on two things. One, I'm very fortunate to be affiliated with Brown University, where it gives me a chance to mentor some very bright students, which is always fun. Next generation gives me such hope. Then also I get to work with the folks at the RAND Corporation as a clinical advisor to their various endeavors. And then the third part-time job I have is I get to be a contributing writer to JAMA Health Forum, which has really allowed me to do what I think you should do early in your retirement, is to take stock and think about the whole process and what you would have changed and what you would like to try to finish off here. I at times I'm frustrated because I wanted to do more. Because when I first started this 30 years ago, I thought, this will be all solved by the time I'm ready to retire. No, but on the other hand, how many people can say that you've spent your life doing exactly something that you're very passionate about, and it's been part of a very rewarding field? So I'm very grateful, but I still wish I could do more.
Well, we'll smile because you've influenced I'm not so young anymore, but I was young when Dr. Janet Bull, whom you know, Janet was my chief medical officer for many years, and I can't tell you how many meetings I'd be in, and Janet would quote you. Well, Dr. Joan Teno says, and we were part of one of your early Brown studies back in 2002, 2003 about caring, long time ago.
Really appreciative.
And I was a little young 30-year-old CEO working with Janet, and the idea of research.
How did that happen? How did all of a sudden we get in our mid-60s?
Wow. I have no idea, but luckily I'm not in my mid-60s yet. But when I reflect on what the number is, and of course Janet recently kind of retired, semi-retired. She's still working as well, but again, the whole point of me sharing that is you have made a great influence, and you've impacted people like me and others who are having to carry the torch. Because I got many years before I'll be at the place where you are. So.
Yeah. And that's what's really most exciting to me is there is a wonderful group of people who are carrying the torch. And that's really, when I first started, we would have an HHPM meeting, and essentially there'd be 300 people in the ballroom. And that was it. Now I think it's like 4,000 people, a lot of really bright young minds who either want to, be a medical director and a leader in their community or doing research. So that's really nice to see. I can remember when I proposed my first research project on advanced directives, my then chair of medicine said, well, that sounds like a nice hobby. Now tell me what you're going to do for your living. So I don't think he would say that to me now.
Yeah. Well, let's jump in. This is one of the podcasts that people have been feeding me questions like, make sure you ask this, make sure you ask Dr. Teno this. So you obviously spend a lot of time around research and measures around hospice care. Mm-hmm. You have the ear of many hospice and palliative care leaders and staff of this podcast. What would you want them to know based on what you've seen and continue to see in the research?
So I think it's really important to not only tell these members, but to tell the general public that, the quality of hospice care remains really quite good. It still is that one segment of the healthcare system that is trusted and rated very highly. That's not going to say that I don't have some heartburn at night. I think there are some small number, my estimate is 8 or 9% of hospice organizations that, the term is profiteering. They're really overly focused on profit. And unfortunately, when you become overly focused on profit, one of the biggest things that needs to be cut is staffing. And, and I think the heart and soul of hospice is the wonderful multidisciplinary team that I've had the privilege to work with. I think the success of the entire field is really related to the wonderful staff that we managed to get to work in hospice, and that on a day-to-day basis, they're the unsung heroes. From the CNA to the bereavement coordinator to the volunteer coordinator, they just do a fantastic job of taking people through one of the toughest periods of their life. So, I think, I think that really reflects why the public, and the CAP survey findings really reflect that, quality of hospice is quite good. Is there some hospices that need to improve? Yes.
Yep.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our May and November 2023 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in end-of-life and serious illness care.
Dr. Teno, for a while I worked for the Studer Group. I was with Four Seasons. I left for 2 years. And my job was to take kind of Studer to hospices. And I don't know if you know much about Studer, but they were kind of a methodology to move patient satisfaction in hospitals. And so I start to see pretty quickly that even maybe mediocre hospices had good satisfaction. And as I reflect on kind of, well, why is that? It is the most brilliant model of healthcare ever devised, in my very biased opinion. And I think a lot of people have benefited. And then you've got good culture, good leaders. They just take that on steroids. But even when you get those things mediocre, that you still get fairly pretty good results, especially compared to other parts of healthcare like hospitals, et cetera. Does that resonate with you?
Yeah, that resonates with me. And actually, to bring it into sort of another point, I think we're at a critical time where we need to update the Medicare hospice benefit, okay? The Medicare hospice benefit was created in the 80s around a disease trajectory of cancer of the 80s. It's never really been applicable to non-cancer patients, and modern medicine has done a really great job with treating some cancers, so that some cancers are really turning into chronic illnesses. And the Medicare hospice benefit now needs to be updated and needs to think about how best to take it into its next second of its half century. But we want to do it in such a way that we're not losing just what you so aptly described. And that's the hard thing is, staff is probably about 70% of your budget. And, one of the ways of becoming efficient and getting a profit margin is decreasing visits. But those visits are just so important to really, the majority of hospices care is at home, and it's dependent on families, and their families really do need the support of those visits. So I feel that, we need to make a transition, but we need to think very carefully about the unintended consequences that could happen when you replace parts of the Medicare hospice benefit.
One question that one of my team members said, you got to ask Joan this. And so is the CAP survey really statistically relevant? Is it really telling us what matters most to patients and families?
So the thing is, the CAP survey does really sort things out. I think one of the problems of the CAP survey is we put it on a scoring range of 0 to 100. And people start thinking, well, 90 is an A minus, maybe, in that good solid range. But I think the way you need to start looking at this is how often you have an opportunity to improve. So a while back, I just took some old data, the family evaluation hospice care data, and simulated one of the scoring systems for the CAPS, a very simplified version, okay, without all the complexities. And so a 90 is actually sort of really equivalent to about, actually to be precise here, 90.8 is equivalent to about 19.7% of people having a concern with the quality of care, okay? And so, I look at this as 1 in 5 saying, hey, there's something we could improve. We really need to try to improve that. The other thing I think we could do a much better job on is really explaining to the field what a difference means. So, for example, a 2-point difference in the CAPS item scores is associated with about a 1.7 likelihood to have someone say that they would not definitely recommend that hospice. A 5-point difference is really the difference between a death in a nursing home versus a death at home. Okay, so these things you start thinking about, 5 points is actually a very big deal. Another thing that we've looked at is actually visits in the last 2 days of life, and being in the top decile, where you have about 94% of people having that visit, and versus being in the lowest decile, which is about 68% lower, having a visit in the last 2 days of life. The difference is about 5.2 points on the timeliness of care, and anywhere between 2.3 and 4.5 points on all the other CAPS measures. So I think the CAPS does do a good job of sorting out hospices, but I want to go back to my first message. Overall, the quality hospice is really good in America, but there are differences that we should focus on. I think one of the things I've been thinking about is really where should we go, okay? And what is the value of these survey items that are in the CAPS family when you apply them to all deaths in the United States? And this is like one of my sideline jobs here, is I get to work with a very bright young students at Brown. And the results I'm going to present her is her senior thesis for which she won an award. So, and she's a future palliative care physician. So a huge shout out to Annie. She did a really great job on her senior thesis. And what she did is she took the National Health and Aging Trend Study, which has a mortality fallback survey, which asks similar items that are in the CAPS survey. And she basically looked at instead of looking at the silo of care, which is hospice, she looked at the last month of care. And the last month is a fairly good proxy for an episode of care, because about 60% of people have one or more healthcare transitions among all decedents. Usually, most important decisions regarding goals of care are made in that last month of life. Now, I know we want to move a lot of this upward, but still the last month is a pretty good proxy for those decisions. And then finally, last month is pretty consistent with when families become involved, when there's a downward functional trajectory, families become involved, excuse me, families become involved, and the families can act either as an expert witness or they're a direct participant in decision making. And they often are the ones who hold vigil or provide the hands-on care to that person in the last week of life. So they have a really important perception. Now, I wish we could interview patients, but it's just too difficult and too intrusive to try to interview people in the last weeks of life. NHPCO tried to do that maybe about 15 years ago, and the response rates were low. The people who they interviewed were, people who went on to live more than 6 months. So it's just not feasible. So the families provide a really good proxy, and also a participant in decision making. But let's get back to Annie's project and her last month. So this is weighted data from 12.6 million deaths. So this is like you do a Gallup survey, one person represents a huge number of people. But applying the weights to these surveys and representing about 10 years worth of data, we found about 1/4 of the people died at home with hospice. 11% died at home without hospice, 10% in an ICU, 6.4% in a hospice palliative care unit, and 6.4% in a freestanding hospice inpatient unit, and 9% about in a hospital without palliative care. By far, the family members rated the highest quality of care, saying 61% of the time the care was excellent, was for those people who died at home with hospice. And when you started looking at that trajectory, okay, the people who died at home with hospice were not the ones who had a terminal hospitalization. They're ones who were enrolled with a good length of stay of hospice. So they're the ones who really are getting the full benefit of hospice. Now, there's two other groups that have either palliative care or they end up in a freestanding hospice inpatient unit. Okay? So, by far, no surprise, the lowest rating of the quality of care were people who died in an ICU. And we did this sort of fancy statistical mumbo jumbo, but basically we adjusted for differences in age, gender, race, disease trajectory. And we found that people who died in an ICU were about 38 points lower than people who died at home on that scale. Okay? Now, people who died in a freestanding hospice IPU were about 17% points lower and saying the care was excellent. And while people who died in a hospital IPU were similarly lower, I think it's about 26 points lower. Now, this doesn't mean that the quality of care was poor in those last locations of care. What it means is people just didn't get to them quick enough, okay, or in a timely manner. And when you don't have those transitions, and you spend the majority of the time in hospice, you're getting the highest perceptions of the quality of care. So I think as we are starting to think about this hospice as an episode of care and thinking about how hospice fits in various forms of population-based health, whether it's a medical shared savings program, ACO, or whether it is a Medicare Advantage program with a potential carbon that may occur. I think it's really important that we look at the quality of care in the last month of life. And that, I think, would provide a good check and balance to tell us not about how good the care was in hospice, but how was that experience for that episode of care. So that's, I think, one direction I'd like to see the field go in, is to start looking at this episode of care in the last month and be an important marker of the quality of care for these population-based entities that are going to, really be, my tea leaves, at least from what I read on the CMS website, is that's the direction they want to go. They want to go into, a capitated payment system that's based at the population level, that may reward quality, or it may, give an upside and downside risk. So I think it's important as we move into these new different capitated payment systems or alternative models, that we do have quality measures that reflect the seriously ill and those who are dying. And I think this is something, and we have a dog joining us in the background, that, technically, I am in their room. This is the dog room of the house, which is also my office, but they really own the room. I think that the one thing that this could accomplish, if we started focusing not only on the entire population, but oversampling those who are seriously ill and those who have died, we can really draw attention to a population that is really high need and high cost. Okay. And, I grew up in the coal mining regions of Pennsylvania, and my grandfather always told me the stories of when he would go into the mines and how he would take a canary in a cage. And that was his way of testing the oxygen back in the 20s. And I really feel that metaphor really extends to the seriously ill and the dying, is they're really a test of how well our healthcare system can respond to complex patients. I will potentially could get the CAP survey, but I see my doc maybe once a year, don't really have a lot of healthcare problems. I'm getting my, that, and I'm on Medicare, getting all my screening tests done so I can avoid that high deductible. But I'm not that exciting. I'm not going to tell you a lot about the quality of care. I think the persons who are going to tell you a lot about the quality of care are those people who are experiencing a serious illness, and they will tell you what went well and what didn't go well. So I think it's really important as we move to these population-based, prospective capitated payment, that we start focusing in on the seriously ill as sort of our really proxy for saying how a stressed healthcare system can respond to someone with a serious illness. And I think that's going to be a good judge of the quality of care, in addition to making sure that they're doing all the usual things, which I think are probably much easier, which is screening colonoscopies and all that good stuff that I've just done in the last 2 weeks.
Well, that's a segue. So the other question I want to ask you, so obviously you're alluding to it, Medicare Advantage is going to become more and more important, not greater than 50% Medicare beneficiaries today. And so are you working on quality measures in that realm? And you recently released a paper in New England Journal of Medicine about this, right?
Yeah, I was very fortunate to work with another sort of bright, young health services researcher, Claire and Kuda, and a whole bunch of health economists. So it was me, Claire, and the health economists crew. And, we really sort of thought, well, look what's happening here. MA continues to grow, and it's, probably 2030, it may be 60% of Medicare beneficiaries are going to be on Medicare Advantage plans. Nearly 1 in 5 dual eligible Medicare beneficiaries are on an MA plan. And, I think you got to give MedPAC a lot of props because, Congress said, MedPAC, tell us how Medicare Advantage plans are doing in caring for these dual eligibles, because they're a frail, vulnerable population. And MedPAC said, I can't tell you because we don't have the right data. And so what we tried to do in that perspective piece is to point out that we really need to take a look at the quality bonus plan and make sure we're developing new measures, okay? And there's a couple things that we pointed out. So one thing, right now, I can tell you this from personal experience because I just selected a Medicare plan. When I looked at Medicare in Rhode Island and looked at the various things, I took a look at one of the plans and just sort of looked at, well, where's this data from? Because everything on Medicare, the Compare website, is by a contract, okay? And over time, CMS allowed MA plans to consolidate plans into contracts. And a contract is an entity that could cover a small region to covering 5 or 6 states. And there was one MA plan that, when they're reporting on the contract level, it covered 6 states. That doesn't tell me a lot about the quality of care that I would get in my home in Rhode Island. So, I think that's one problem, is that they have a reporting unit that in some cases covers a fairly big geographic region. And we know from Jack Winberg's work in the Dartmouth Atlas that all healthcare is really local. So, it's where you live determines that. So I think that's one problem with the QBP, or the quality bonus plan for MA. And the second one is just what I was alluding to. is, I think they really need to probably have a sampling design where they oversample people with serious illness and see what their perspective is on the quality of care. I think that they, in addition to their usual sampling strategy, I think they should look towards developing a specific module just for people with serious illness and employ that as a way of understanding how a high needs and potentially high cost population is dealt with in that Medicare Advantage plan. And that's something already another one of our national surveys does, called the Health Outcomes Survey. So, I think that's really important. A few other things that we called for is a lot of people are choosing MA plans because of the supplemental benefits, from the Sober Sneakers program to free rides to additional thing. But we have no information on how often they're provided to the beneficiaries. So I think we should have transparency on how often it occur. And then, I think as CMS is working with the encounter data, they need to continue on the path of trying to make sure that the Medicare encounter data for MA plans is complete and accurate as possible. So we're hoping to stimulate a dialogue about the MA plans quality bonus program in the hopes to make sure it provides actionable information for consumers. And then really, for the people who are seriously ill, they will at least have some quality measures that reflect information that will help them guide to choose which MA plan they should go with.
Wow.
And I have to admit, this is all very confusing. I'm sure, for the general public, they probably don't realize what's the difference between the parent organization, the contract, and the plan. Right. They opt into a plan, but a plan is part of a contract, and a contract relates to the parent organization. And I think it's just got to be really confusing for the consumer to go through the Compare website not understanding where the data is coming from. So, I think we need to do a better job of educating our Medicare beneficiaries, educating me, the boomers, on how to do this.
It sounds like it's very entity specific and not customer centric.
Yeah.
Which, being an accountant by trade, so I could see how those chutes and ladders are working. That's a great, that's a great call out, Dr. Teno.
Thank you.
So what final thoughts? Again, I learn so much every time I listen to you. What final thoughts? You've got the year of hospice and palliative care leaders and staff and such a rich history of research and thinking and just passion for this work. So what final thoughts?
Yeah, I really hope they keep their passion. What inspired me from the onset was working in a multidisciplinary team that really drew together a biopsychosocial functional values model of care. People were not just a disease entity, but a person in the context of their family. And I really like that approach to thinking about medical care. I think the danger is, as we go to think about how to improve the Medicare hospice benefit, that we don't lose that focus, that we don't forget what is the historical roots of hospice. And, while I know everybody's calling for updating of the benefit, because I think there, some really, the disease trajectory has changed, but I don't want to forget, I can remember as maybe an 8-year-old getting Life magazine, and the picture on the cover of Life magazine at that time was a cancer patient writhing in pain. Okay, and what these earlier innovators in hospice did was really make that picture very rare to occur these days. And that is an important accomplishment. Just, how to appropriately use medications and how these medications can be used safely to palliate the people. And, one of the people I had the honor of meeting several times was Dame Cicely Saunders. She probably is the most eloquent speaker I've ever met in my life. And I was at the 30th anniversary of St. Christopher's Hospice, and one of the words she said is really calling attention to the importance of patients' own views on what they need. And I think we're in this era of evolving value-based medicine where costs are very easy to measure. But we need to stay true to those words and don't forget about the quality side of the equation. And I think it's going to be important for hospice to advocate for quality and the right quality measures to make sure that we're not forgetting this frail, older, vulnerable population with a lot of needs.
Wow. Well, again, Dr. Teno, thank you. In fact, we always leave folks with a quote. So Dr. Teno already created the teaser, and so I asked her a great quote. She gave me this quote. So I'm going to weave it together because she has her own words. I'm going to weave Dr. Teno together with Dom Cicely Saunders. And so this is first Dr. Teno. Throughout my career, the words inspired me. The importance of patients' own views on what they need. Now back to Dr. Teno. So that was Dom Cicely Saunders. In this era of evolving value-based medicine where value is determined by cost and quality, that's value, that's the value equation, we need to stay true to the words of Cicely Saunders and don't forget the quality side of the equation. So Dr. Teno, thank you. Thank you for your incredible career. And I'm sure you'll probably continue to work, but just maybe a little bit less, right?
More time taking pictures of dogs and posting them on Instagram for people to laugh at me.
Well, we thank you. And thanks to our listeners. Thanks for listening to TCN Talks.